to carry out any number of tasks at one time. So if I ask you to do two things at the same time and you don't have enough energy to do those two tasks, then you'll blow out. So you were good one way, but not another way. So open this up, open this up, open your mouth, hold, close your mouth tight, hold, open halfway, move your jaw to the right, hold, move your jaw to the left, hold, okay, wink, hold, wink, hold, smile, hold, frown, hold. Because he's got a facial nerve, trigeminal. Smile, frown, hold, okay.
You broke it.
Lie face down, give her a piece of face paper.
Face paper is right underneath.
Can we have a clean piece of face paper?
Right there on that, right there.
Right there, right there. Cough. Okay, again, cough. You're looking at getting close here with your camera. Cough.
Straight up.
Straight up.
SB plus.
So she's cranially in.
She's stuck in, is it extension?
Yeah, she's stuck in extension. Turn over on your back. Now, what we want to do is we want to put the spheno-basilar system back into flexion. So, that means that the spheno-basilar, the floor of the skull, has to elevate medially, the temporal bones have to flare laterally, the occiput has to move posteriorly as the basal portion lifts up anteriorly, and the frontal bone and the vomer and the sphenoid have to do this. Inhale, exhale, inhale, exhale. So what we need to do is we need to put flexion in there. So one of the best ways to do that, or one of the most direct ways to do that, is to come right behind the hard palate into the soft palate and push straight up into the spheno-basilar mechanism. Why is that not a good idea?
Soft tissue.
A lot of soft tissue stuff down there, isn't there? Blood vessels and nerves and ganglion fibers and all kinds. The osteopaths actually tried that, but it was so bad. So we need an indirect method to try and make that spheno-basilar go into flexion. So what structures do we have that will allow us to do that? Dr. DeJarnette said to do an occipital extension, which is to move the hands this way while you push up and back on the hard palate, on the midline of the hard palate. But when I look at that anatomically, what happens is you're forcing the sphenoid into extension instead of flexion. I said, that's not what you're trying to accomplish. He was, of course, gone by the time I could explain that, and at the same time, I really didn't want to explain that to Dr. DeJarnette, that I thought his technique was wrong. But in fact, Dr. Pick has completely redone all of intraorals to suit, his understanding of sutural mechanisms now that he's done so much anatomical dissection. And so he says that the temporal bones, they used to say the temporal bones rotate this way. They really don't. What they do is they flare laterally. And the parietals lift up, the frontal bones hinge, okay? And the sphenoid has to tilt forward, which means you have to drag the sphenoid, the rostrum of the sphenoid forward by distracting the maxilla and the vomer inferiorly to drive the posterior aspect of the sphenoid up. So what three structures can I use to do that?
Use sphenoid?
Sphenoid, you want to influence the sphenoid, but what can you do to influence the sphenoid? What is just above the maxilla on the midline? I just mentioned it. Ethmoid's there, but you can't really, the ethmoid's spongy. There's some flexion that takes place there.
No.
The vomer's there. So you have to use that vomer, but what you have to do is you have to get that vomer to come down and up in order to bring the sphenoid this way. Mm-hmm. You have to pull down on the rostrum in order to elevate the spheno-basilar junction and the ethmoid area, that there's some flexibility there too. So you want to create that kind of flexion. Now, what other two structures can I use?
What about your temporal bones?
What portion of the temporal bones?
Parietal? Well, no, with the
The hardest bone in the body. The most densely calcified bone in the body is that portion of the temporal bone known as the petrous
petrous.
portion. And what do we know about the petrous portion? Where does it come into? It butts directly into the spheno-basilar junction. So, if I have the vomer here, and I have the two petrous temporal bones here, what do I have? I have a tripod.
This is the tripod you were talking about.
This is the tripod technique. Give me your tripod. Bring your tripod here.
Do you need a glove for this?
Not for that part, but I will in a minute, yes.
I just don't get how you're gonna adjust her with this.
Oh, goody.
Okay, now, let's see here. Here's the vomer, right petrous, left petrous, okay? If you think of it this way, here's the I'm going to have to contact the maxilla in order to change the position of the vomer to raise the spheno-basilar junction. So think of this as the spheno-basilar junction. It's an extension. I need to close this in order to raise that. What contacts can I use to do that? Inhalation, exhalation. Inhalation, exhalation. If I contact the mastoid tip, process body and tip here, and the process body and tip here, and I contact the maxilla here in just the right way is to tilt it forward anteriorly and superiorward in the posterior aspect, I can close that triangle, thus raising the spheno-basilar junction using an indirect method, or a direct method, but using it as using the structures of the skull without endangering anything inside there. So what we're going to have to do, who knows what RTRT is? Have a seat.
Please let it be.
If they taste funny, let me know.
Who was it?
Okay, so take the RTRT position. Let me see here. Right down, Thenar's right down on the mastoid process body, no, right on the mastoid process body and tip. Now, you're going to flare your elbows, and you're going to bring the mastoid tips medially.
Mm-hmm.
And then you're going to go this way. And what I'm going to do is I'm going to grab the maxilla just above the alveolar margin, and I'm going to come right in here on the midline. Instead of doing this, I'm going to tilt that maxilla, take a deep breath. I'm going to push down on the anterior and lift up on the midline. And you're going to flare your elbows and push those medial tips forward. Very nice. Let's do that one more time. Breathe out and breathe in. See the difference? This is happening on the maxilla instead of this. Okay? You can let it go. Turn over now.
I feel high.
I'm going to get high, high, high in the midday sun. I'm blowing my face to take blowing my day to take a walk in the sun. Blowing my face in somebody's new mode. I've been having a sweet dream. Been dreaming since I woke up today. Okay, cough. Again. See the movement now? Cough. Up and over. So she's back in neutral. Okay, she's going into flexion and extension. Now stand up.
Yay. Oh, yeah.
Now we can test the cranial nerves again. Fist, hold, smile, frown. hold, hold, follow this way, hold, 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 in, hold. Can you hear this?
Yeah.
Can you hear this?
Mhm.
Okay, can you, you don't have, usually you can give them something to smell. Okay, wink,
Prostate gloves.
Yeah.
wink, hold, wink, hold. There you go. You're back in the saddle again.